Our next speaker is Johnny Mulheron from New Zealand, and he will review evidence on mechanical versus manual chest compressions. He is clinical practice manager at St John, New Zealand, and an intensive care paramedic. He has worked as a critical care paramedic in Qatar and extensively used pre-hospital mechanical CPR. And he writes the Backcountry Accidents column for the New Zealand Federated Mountain Club's Backcountry magazine. In fact, I came across something, he, at some stage, maybe still, was with the Nelson Marlborough Rescue Helicopter Trust. And there's a fascinating article about that, which talks a day in the life of that, which was quite a tragic day because they had some pretty serious cases to deal with. And just one paragraph from an article I read, Johnny had walked out of the hospital, ducking under the spinning blades of the helicopter, and is simply told, and he's had a really, really bad day up to this point because of the seriousness of issues, and is simply told, we have another job. And so he's back in the air, attending again. So looking forward to hearing Johnny Mulheron. Please welcome him.
Yeah, mine's going to be a bit of a personal journey about a very interesting topic, and I hope at the end of this that we can get some clarity about mechanical versus manual chest compressions. It's an ongoing topic. So, personal journey, my relationship with mechanical CPR and manual CPR in my career. We're going to look at the chest compression evidence and review of that, teaching you to suck eggs probably. We're going to look at the mechanical chest compression evidence. Going to look at the limitations, confounders and challenges in resuscitation science. I'll just start my timer. And we'll look at a couple of current mechanical chest compression trials, and then we'll conclude. So thanks, Lynn, for that introduction. I'm intensive care paramedic for the last decade in New Zealand, and I had very limited exposure to mechanical chest compressions in New Zealand. And then I did a contract in 2011 for 2 years in Doha, Qatar, and I had massive interaction and experience with mechanical CPR. And I observed, anecdotally, phenomenal results, remarkable perfusion, colour, peripheral pulses and patient movement, much more than I'd observed in manual chest compressions. Change the slide. That's Doha, Qatar. They're building a Manhattan skyline out of the desert. So Qatar is a population of 2.6 million. The main city is Doha, which is 1.5 million. Of that 2.6 million, remarkably 2.3 million are expatriates, mainly from the subcontinent, India, Nepal, Bangladesh, Pakistan, among others. It's the world's highest per capita income. It has the world's third largest oil and gas reserves. It's currently doing a US $250 billion infrastructure building program. And it has a state-run, Hamad Medical Corporation, who I worked for, EMS and hospitals. So it's a bit in the news at the moment, Qatar. 2022 Football World Cup is being held there, and is in a current conflict with other Arab states. And the Al Jazeera television channel is broadcast out of Doha. So yeah, extensive use of mechanical compressions in Qatar. Why is that? Epidemic levels, in my opinion, of sudden, unexplained, non-traumatic cardiac arrest in 20 to 35-year-old males, really fit males, expatriates from the subcontinent. What the heck was going on? Because I've never seen that before. You get a few of those, in New Zealand, long QT syndrome, that sort of thing, but nothing like I'd seen there. There's some of the expats. So, what's going on? These guys work 12 hours a day, 6 days a week, hard physical manual labour in greater than 50-degree temperatures. Interestingly enough, they were meant to be stood down when it got to 52 degrees. I never saw them stood down. Apparently it never gets to 52 degrees in Doha, but I can assure you it does. Measured 60 on many days. They live in industrial compounds, 12 men to a dorm room, or more than 12, with one clapped out air conditioner, okay, if they're lucky. It's called kafala, which is sort of forced labour. Their passports are taken when they arrive. They have to get an exit visa and from their sponsor, their employer. So it's described as an open jail. And they live off desalinated water and very basic diets, chapatis, rice, that sort of thing. So we think this massive death rate or cardiac arrest rate is from electrolyte imbalances leading to cardiac arrests. The science is being done now, and I'm sure it will show that. So that's why I had extensive experience with the Lucas 2 mechanical compression device. So we did very prolonged resuscitations. That was mainly for cultural reasons. If they were a VIP, a VVIP, a VVVVIP, royalty, you had to be the right status to call death, and I wasn't that status, so we had to transport with mechanical compressions to hospital to find that status. There was also sort of ad hoc treatment, what I'd call bridge to treatment, such as ECMO and PCI to clear blockages, but it wasn't in a formal capacity. Let's quickly teach you to suck eggs and review chest compressions because I think it's important. So in the setting of cardiac arrest, high quality chest compressions maximise coronary perfusion pressure, and that's a primary physiological goal. They improve myocardial blood flow, improve blood flow generally, improve vital organ, cerebral and coronary perfusion, and they improve the likely success for heart restart interventions such as defibrillation and PCI. And we know that chest compression metrics, the quality of them is highly variable in the field. So what about the rate, depth and quality of chest compressions? We know that patient survival is linked to chest compression metrics and quality. We know that there needs to be a rate of 100 to 120 per minute. We know that the depth has to be greater than or equal to 50 millimetres up to an average of 55.3 millimetres in adults, or greater than or equal to 1/3 of the chest width in children and infants. We know there has to be full recoil to allow venous return. And we know we've got to have a high chest compression fraction, minimising hands-off time and interruptions. What leads to degraded chest compressions? Functional and survival outcomes are downgraded in adults with as little as 5 millimetre chest depth variance, so very small variances. In adults, if the chest compression is less than or equal to 38 millimetres, survival drops 30%. If the chest compression rate is less than 100 per minute, we get ROSC reduction of 30%. In manual chest compressions, we know there's incomplete chest recoil, which leads to reduced coronary perfusion pressure, reduced myocardial blood flow. We know that with a reduced chest compression fraction, we get, again, reduced coronary perfusion pressure and myocardial blood flow. And we know that if you increase chest compression depth up to 5 millimetres or more, up to a certain point, we improve survival outcomes by 30%. That's up to about 60 millimetres. So what causes degraded chest compressions? Well, the force required may exceed the practitioner of manual chest compression's ability, particularly those with lower body weight. We know that there's varied training and skills in both manual and mechanical chest compression application. Leaning is a phenomenon where we don't allow full recoil, which is particularly relevant and observed in manual chest compressions. And it can occur with as little as 10% of the practitioner's weight causing leaning, causing reduced chest recoil, which reduces perfusion. And we know that the guidelines that have targeted increased chest compression rates and depths have led to increased likelihood of leaning in manual chest compressions. We know that fatigue in manual chest compressions is a problem affecting the metrics. We know that there's increased hands-off time and interruptions in manual chest compressions with interventions that are done and practitioner changeover. And we know that there's increased hands-off time when you transition from manual compressions to mechanical. If we get a chest compression fraction of greater than or equal to 80%, with manual chest compressions. That's achievable with good CRM, crew resource management, and mechanical chest compressions can significantly contribute to good scene management, and it reduces the cognitive load on the practitioners. So the previous speaker just mentioned some real-time manual chest compression feedback devices. They reduce variability in manual compression metrics. These devices in the simplest form are like a metronome, and in the more complex forms are pressure sensors which give feedback on depth and recoil, etc. And they can improve delivery of manual chest compressions. Mechanical compression devices, real-time responses to the sensors within the mechanical machine, and there's no risk of distractions. Mechanical measurement of chest compression metrics is more accurate than manual observation, estimates, judgment, and gauging. So, mechanical versus manual chest compressions. Manual compressions appear to work best when performed with machine-like delivery. Chest compression metrics lend themselves to mechanisation in a similar way to ventilation metrics lend themselves to mechanical ventilation. In postgraduate studies, I examined the literature to see if my observations of apparent increased perfusion during mechanical compressions matched the evidence and improved survival rates from cardiac arrest. The Cochrane Review 2014. They stated, in cardiopulmonary resuscitation, machines should be able to provide a more effective pumping action than is seen in humans because the machines do not pause or get tired, and they provide consistent pressure and timing of each chest compression. Are chest compression metrics suitable for mechanisation? They're rhythmic, repetitive, accurate, consistent, incessant, and measured. So absolutely yes. Humans must merge with machines. Elon Musk, absolutely correct and absolutely happening right now. The machines have already won. I'm not convinced of that, but not far off. Right, measurable benefits of mechanical chest compressions. End tidal CO2, carbon dioxide, is a measure of pulmonary blood flow and cardiac output during chest compressions. Prospective animal randomised controlled trials of mechanical chest compressions empirically measured significant increases in end tidal CO2, increases in cardiac output, increases in coronary perfusion pressure over manual chest compressions. Prospective human randomised controlled trials of mechanical compressions empirically measured significantly raised end tidal CO2 over manual. In moving vehicles, we know that mechanical chest compressions are very poor when compared, in moving vehicles, mechanical chest compressions are way more advantageous than manual chest compressions, which have been measured to be very poor. And in mannequin studies of mechanical compressions, mechanical compression metrics improved over manual compressions. So do the clinical studies of out-of-hospital cardiac arrest with mechanical compressions show improved survival? AHA, American Heart Association Guidelines 2015. They recommend against the routine use of mechanical chest compressions. They note that mechanical chest compressions are a reasonable alternative when manual chest compressions are impractical, compromise safety, such as in transport, or are prolonged. Let's look at some of the systematic and meta-analysis reviews of the literature of mechanical versus manual compressions. 2016, Lee et al., no differences in cerebral performance category, and concluded that mechanical compressions cannot be recommended as a replacement for manual compressions. 2015, Gates et al., mechanical compressions not superior to manual compressions for routine use. And 2014, the Cochrane Review, that's Brooks et al., there's insufficient evidence to conclude that mechanical compressions are associated with benefit or harm. I'm sure some of you are scientists in resuscitation science. Real-world resuscitation science is extremely difficult. There are many confounders. It's complex with many variables, including, which leads to very complex and challenging study structure. Cardiac arrest has a high mortality and therefore a lack of data. The chain of survival, which link has the most benefit? Non-blinding, selection bias and the Hawthorne effect are all issues in resuscitation science. Inconsistent deployment and training, particularly with mechanical compression devices, and changes in guidelines during trials. And there's also futility perceptions with high mortality in cardiac arrest. So let's look at a couple of the big trials and see if there's any limitations to them. The PARAMEDIC Trial of 2014. This trial found that mechanical chest compressions for routine use does not improve survival. In the mechanical arm of the trial, mechanical chest compressions was only used in 60% of the cases. Not sure the reason why. Might have been crew error or they weren't adequately trained. It might have been the bulk, the weight and the lack of familiarity with the chest compression device. There's also what was the influence of other interventions in the study, such as the impedance threshold device, targeted temperature management. There was inconsistent deployment and training and application of mechanical chest compressions. And here's a big one. Mechanical chest compression devices were applied before defibrillation, delaying early defibrillation in the mechanical chest compression arm. That's fairly significant. There was limited data on the chest compression fraction. The quality of manual chest compressions prior to mechanical was not measured. The length of collapse time was not factored in, and the time to first shock not measured. So are these results from the PARAMEDIC trial, are these results from the mechanical chest compression therapy itself or from the quality of implementation of the mechanical chest compression device? Another really big trial was the LINK trial, 2013. Again, found no significant difference in manual versus mechanical chest compression survival at 4 hours, which was their primary endpoint. Chest compressions were interrupted for a median of 36.0 seconds, transitioning to mechanical chest compressions, which I found astounding. That's a very long time. Mechanical chest compressions and the algorithm training was done every 6 months, so they did train the practitioners very well. There were 2 different algorithms for the manual and the mechanical arms, and that was designed to minimise interruptions to mechanical chest compressions. The Hawthorne effect definitely kicked in here with the manual group competing very hard to beat the machine. The mechanical group received a defibrillation shock at 90 seconds regardless of the rhythm, and the first shock in the mechanical arm occurred 90 seconds later than the manual arm. The mechanical arm had 3-minute chest compression rounds as opposed to 2-minute chest compression rounds for manual chest compressions. And that was because they thought practitioners would tire at the 2-minute mark. So 2 current mechanical chest compression trials. These trials have a high degree of pre-hospital and pre-hospital and in-hospital inter-operation. There's very specific inclusion and exclusion criteria. So the Minnesota Resuscitation Consortium, 2016, so for that cohort of patients with refractory primary VF, VT cardiac arrest, they were onto mechanical chest compressions, impedance threshold device, transport, other ACLS interventions, targeted temperature management, ECMO and PCI. That endpoint of that cohort was 50% discharge with a cerebral performance category of 1 or 2. That is a phenomenal result because currently under manual chest compressions, they're pretty much dead, that full cohort. So that to me is a phenomenal result. The other current study is here in Australia, the 2-chair study. And there might be people here who know more about it than me. But again, refractory primary VF cardiac arrest. They go to mechanical chest compressions, transport, targeted temperature management, ECMO, PCI, endpoints of discharge at 90 days, mortality, cerebral performance category 1 or 2, and a secondary endpoint of ROSC or ICU discharge. I believe they're getting really good results. If there's anyone involved in it, I'd love to hear from you. So in conclusion, that the literature does not demonstrate overwhelming mechanical chest compression benefit does not mean that there is none. The limitations, difficulties and challenges in real-world resuscitation trials are very, very significant. Cost, bulk and futility perception will continue to be barriers for routine mechanical chest compression devices. Mechanical chest compression devices allow transport as a bridge to treatment, such as PCI. Mechanical chest compression devices improve crew resource management, scene logistics, and reduce cognitive load of practitioners. I predict we're on the cusp of mechanical chest compression devices becoming routine bridge to treatment tools for refractory primary cardiac arrests likely to benefit from transport to definitive reperfusion interventions. Thank you very much.